Thank you very much. It's Atlal Abusanad. I'm an assistant professor of internal medicine and medical oncology at King Abdulaziz University Hospital. I'm delighted to be invited to this forum. Thank you very much. So briefly, I'm going to take you through the developments of targeted therapy in ovarian cancer, which I find very fascinating. I'm going to start with the anti-angiogenic agent. Majority of the talk going to focus on vascular endothelial growth factor monoclonal antibody. I'm going to discuss the trials in the first-line setting as well as the recurrent setting. We will touch a bit on the TKIs in ovarian cancer, and of course, no talk should be without discussing PARP inhibitors, briefly EGFR and HER2 inhibitor as well. To start with, angiogenesis is a very crucial mechanism for cancer to survive, progress, and metastasize as well. And once the tumor reaches 1 millimeter to 2 millimeter, it will start acquiring and secreting vascular endothelial growth factors to form new blood vessels. Angiogenesis happens through different mechanisms. One of the most important one is through the vascular endothelial pathway. From early phase study, animal studies as well, and preclinical studies, we found that vascular endothelial factor receptors and ligands are both overexpressed in ovarian cancer, as well as it's been shown that it's associated with formation and accumulation of malignant ascites, malignant pleural effusions, as well as carcinomatosis. It's not only that, but it correlates as well to poor prognosis in form of increased death risk and recurrence. This busy figure shows the vascular endothelial growth factor receptor pathways, which is multiple receptor targeted by multiple growth factors. And it's been the target of multiple pharmaceutical development recently. As you can see here, bevacizumab, it's a monoclonal antibody that targets the vascular endothelial growth factor A, and because the target is in the circulation, you find the CI in the name. And the ZOO stands for the fact that it is a recombinant humanized monoclonal antibody, majority of it from human, however the antigen binding type comes from mice. That's and MAB because it's monoclonal antibody. Early phase trials with a single agent, bevacizumab, in ovarian cancer patient who has been on multiple lines of chemotherapy and progressed, showed a nice response rate. If you look there at the GOG 170, you see the response rate is 21%, which is considered in medical oncology something very high. That's why bevacizumab was graduated into later phase trial, and it was taken into the first-line setting in treating ovarian cancer. And you see here the schema for the GOG 218 trial. It's the first one conducted in untreated ovarian cancer. As you see here, they included patients with advanced disease who had surgery, whether optimally or suboptimally debulked, and it was a three-arm trial. Patient in arm 1 received carbo plus paclitaxel, and in arm 2, carbo plus paclitaxel plus concurrent bevacizumab just during the chemotherapy course, while the third arm received carboplatin paclitaxel, concurrent bevacizumab, followed by maintenance as well. Interestingly, the result comes as positive for progression-free survival, and you can see the hazard ratio is quite significant, but the overall survival was similar in all three groups. They also addressed the quality of life as secondary endpoint, and initial analysis showed some detrimental effect for adding bevacizumab into the chemotherapy. However, in the final analysis, there was no difference between treatment arms and placebo arms. The second, well, this is the safety profile. Initially, when this drug was added in a phase 2 trial for chemotherapy in ovarian cancer patient, many ovarian cancer patients developed GI perforation, which was a downside for adding bevacizumab. However, those patients were not selected. But in the phase trials of patients, they select the patient who didn't have risk factor for GI perforation. They excluded any patient with involvement to the bowel with the cancer, as well as any evidence of radiographic involvement to the GI. And you can see here, if I can get the point out, okay, right. So GI event, including the perforation, no, the perforation is not included here, but the perforation was something like 1.3%. Other side effect was consistent what we know for bevacizumab from our experience in colorectal cancer. Quarter to 1/3 of the patient developed hypertension, and some patients developed proteinuria. Of course, we don't give bevacizumab for patients who had previous history of either arterial thrombosis, stroke, or MI. Again, the ICON 6 came to replicate the result of GOG 218, but this one is more neater in my opinion, because it's only randomized the patient into 2 arms. One arm treated with our regular chemotherapy protocol, and the other arm with the chemotherapy plus bevacizumab, and they continued bevacizumab after the chemotherapy was finished as well for a year. The new thing about this trial, it included also early stage ovarian cancer with high-risk feature, either clear cell histology or grade 3. And they stratified the patient into high-risk group and average risk. High-risk group included the one with stage 3, suboptimally depulked, or inoperable stage 3 and 4 as well. Again, the primary endpoint was progression-free survival, and as you can see here, it's a significant improvement in both average risk and high-risk population, with hazard ratio of 0.8 in all patients, and with the difference of 2 and 3 months improvement. But in a high-risk group, the difference is even more. The gain in progression-free survival is 5 months. This is the update from 2013, and more or less it shows the same thing regarding progression-free survival. But overall survival, again, was disappointing for all patients. However, as I mentioned earlier, with the stratification into high risk, they found that it is significant for patients in that group with hazard ratio of 0.78. This is the side effect profile of the ICO-7, and again, the GI perforation was not a big event here. It's 1.3, more or less similar to what it's been noted before in the GOG trial. Recurrent platinum-sensitive ovarian cancer it was thought as a good disease entity to test bevacizumab, and OCEANS trial, which was previously mentioned by my colleague Dr. Al-Khayyat, and again, it's a neat trial with some downsides. They used carbogem plus placebo and carbogem plus bevacizumab. Again, the good thing in this trial, they give bevacizumab till progression. Oops. All right. So again, the primary endpoint was progression-free survival, and as you can see here, there was a significant improvement with a very impressive hazard ratio of 0.48. And the response rate was much better for the bevacizumab group. as well, but again, disappointing overall survival with no difference in the treatment arms. Side effect, more or less similar, and actually there is no GI perforation in this trial at all. And again, it's basically related to better selection of patient. Then came the Aurelia trial, which addressed the question of using bevacizumab in platinum-resistant ovarian cancer, which is considered a challenging entity to treat. So they included, let's say, heavily pretreated patient, and they randomized them for chemotherapy and chemotherapy of investigator choice plus bevacizumab. So the chemotherapy on this trial were paclitaxel, topotecan, and pegylated liposomal doxorubicin or Calyx. And they stratified according to the chemotherapy selected, and we're going to look at this result because it's quite interesting. Progression-free survival, again, was significant with very impressive hazard ratio, 0.48, and here you can see the progression-free survival across all groups, and as you can see, all groups benefit from bevacizumab significantly, and more patient with ascites. If you look here, ascites, yes, and it's slightly, the hazard ratio is 0.4, which is one of the good ones. It's again, overall survival is disappointing with no improvement in overall survival. However, as I mentioned earlier, they looked at the chemotherapy that used in each group, and if you look at the first trial, the bevacizumab plus paclitaxel gives a 22.4 months versus 13.2 months with the hazard ratio of 0.64. It's clinically meaningful, however, is not statistically significant, but the difference is huge. The other thing that is very interesting in Aurelia trial, that it is associated, the use of bevacizumab was associated with significant reduction of the paracentesis throughout the chemotherapy treatments. The first two columns, the white one shows us the chemotherapy group, while the pink one shows us the bevacizumab plus chemotherapy. And it's a cumulative, and you can see that the number of the patient who required paracentesis throughout all treatment cycle, and the difference is significant. Adverse effect, again, more or less, it came consistent with what we know about bevacizumab. GI perforation is, again, 0, and as I mentioned earlier, it's because of the exclusion criteria of any patient with GI involvement by the tumor or radiographic evidence, or previous history of bowel obstruction less than 6 months from randomization time. So in summary, so far we have investigated bevacizumab in first-line therapy, and we have ICON-7 and GOG-218. Both showed improvement in progression-free survival. However, there was no overall survival advantage. Yet, there is a trend toward improved overall survival in high-risk patients. In recurrent platinum-sensitive, we have OCEANS, and it showed a significant improvement of progression-free survival. However, again, the OS benefit is disappointing. Aurelia, which addressed the use of bevacizumab in a challenging entity, which is recurrent platinum-resistant ovarian cancer, showed a significant improvement in progression-free survival. Overall survival was not statistically significant. However, it was clinically meaningful in the paclitaxel group. There is palliative benefit, especially in patients with ascites. Then I'm going to briefly touch on the vascular endothelial growth factor, TKIs. There is a trial that is called ICON-6, and it's addressed the use of cediranib. in platinum-sensitive relapsed ovarian cancer. The good news, it is a positive trial for both progression-free survival and overall survival. However, the toxicity was very high. The company that is making cediranab has halted its development. Actually, it's not because of the ovarian, but it's because its failure to show any significant survival result in other tumor sites. So perhaps with this result, they're gonna readdress or I don't know, restart developing the drug again. Perhaps, we'll see. The other one is the AGO-OVAR16, which addressed the use of pazopanib. Again, it was positive for progression-free survival. However, there was no difference in overall survival, but the toxicity was very high, and GlaxoSmithKline has withdrawn their application for approval because of the high toxicity. PARP inhibitor. It's been around for some time, and I have close relationship with PARP inhibitors. My master degree was on one of them, so, but in colon cancer. PARP is an enzyme that is responsible for the base excision repair in DNA damage. When the base is not repaired, that will result in a single-strand DNA damage. And when there is a single-strand DNA damage, the replication machinery will stop, and that will result in a collapse of the replication fork. Subsequently, double-strand DNA will result. And here comes the role of BRCA1 and 2 to repair the double-strand breakage. So olaparib was tested in ovarian cancer, and it's given concurrently with chemotherapy, then followed by maintenance as well. The data shows that progression-free survival is significantly improved with impressive hazard ratio of 0.51, as well as they stratified the patient according to the BRCA mutation. And if you look to the right side of the screen, you see the hazard ratio is even more impressive in patient with the BRCA mutation of 1.8. Also, there was a trend toward improved survival in BRCA mutated patient, but not in the whole cohort. And it's been approved recently by the USA FDA. Conclusion. Olaparib showed significant progression-free survival improvement when combined with chemotherapy in platinum-sensitive relapsed ovarian cancer. And it was quite tolerable drug. Toxicity was very mild. Briefly, I'm going to touch on the EGFR HER2 inhibitors. This slide shows the early phase trials of this some of the EGFR HER2 inhibitor. As you can see here, all the response rates were very disappointing, except for the erlotinib plus bevacizumab. However, there is a randomized phase 3 trial that addressed the question of erlotinib use in ovarian cancer, and it came as completely negative trial with no improvement in progression-free survival or overall survival. And the benefit here of 15% is due to the bevacizumab rather than the erlotinib. In conclusion, targeted therapy in ovarian cancer. We have bevacizumab as the first anti-VEGF agent to show improved progression survival with manageable side effect profile. Vascular endothelial growth factor receptor tyrosine kinase inhibitor showed improved outcome. However, the toxicity was simultaneously increased, and we're still waiting for other trials. Several anti-angiogenic agents are in development. And up to date, there is no anti-EGFR or HER2 agent with improved outcomes in ovarian cancer. Other things to touch on, overall survival has been the gold standard in assessing any new agent. However, overall survival requires a long period of follow-up that might be difficult to obtain in our patient or population, as well as we need large number, and sometimes it's really difficult to accrue. Also, we don't have control in certain circumstances on the post-progression treatment, which may confound the overall survival result. Not only that, but all the trials that have shown to you allowed crossover upon progression to the bevacizumab arm. That might have diluted the effect of bevacizumab. Other thing, we need to look for alternative endpoints: progression-free survival, quality of life, perhaps combined together, response rate, rather than overall survival. As well as surrogacy between progression-free survival and overall survival should be investigated further and established. Like in breast cancer, for example, HER2 breast cancer, we know that disease-free survival correlates well with overall survival, as well as progression-free survival correlate well with overall survival. We need to better select our patient to minimize the side effect and maximize the benefit of this treatment. And of course, we need to molecularly characterize this ovarian cancer in a better way to direct our therapy. So we have only the iceberg model in here, and we have only the answer to the very few questions, and yet many answers to come, inshallah ta'ala. And this is my closure. وَمَا أُوتِيتُم مِّنَ الْعِلْمِ إِلَّا قَلِيلًا. Thank you very much.